I'm now going to introduce our next speaker, Dr. Klute, who's one of our medical oncologists. She's going to be talking about navigating the neoadjuvant space in pancreatic adenocarcinoma.
There, I'm Kelsey Klute. I'm a medical oncologist and assistant professor here at UNMC, and I'm going to talk a bit about chemotherapy. I'll touch a bit on radiation, but I'll leave most of that to Chi. So we'll go over some of the rationale for neoadjuvant therapy. I'll discuss one of the more updated trials that was reported at ASCO earlier this summer, SWOG 1505. Discuss some of the evidence-based support for neoadjuvant approach, and then a bit about practically how we approach these patients. So while, at least as far as we know, we can't cure pancreas cancer without surgery, but we know that chemotherapy has significantly improved survival, both for patients with advanced disease as well as for patients with localized disease. Sorry, I couldn't see the mouse. Historically, gemcitabine and 5-FU monotherapy were old standards. They, median overall survival with these agents was around 6 months. Whereas with more modern combination chemotherapy like FOLFIRINOX and gemabraxane, we're seeing overall survival in metastatic disease, median overall survival of 11 months, as well as response rates on the order of 20 to 30%. Systemic therapy also confers a survival advantage for patients with resected disease. In the kind of most updated data from adjuvant FOLFIRINOX, we saw a median overall survival of 54 months. And these are, survival curves that we don't normally see when we're talking pancreas cancer, whether it's earlier metastatic. So in many institutions, neoadjuvant therapy has become a standard approach to treating localized pancreas cancer. For the 20 to 30% of patients with localized disease, there's been a significant increase in the use of neoadjuvant therapy. While we have really limited high-level evidence to support this approach, we do have data from single-arm studies supporting the safety and feasibility of neoadjuvant therapy. But whether a neoadjuvant approach truly improves survival over upfront resection, we don't know. That being said, there are some proven advantages to systemic therapy prior to surgery. And through the course of this talk, I'll review some of the updated neoadjuvant studies and highlight the data that supports these points. But some of the advantages of using neoadjuvant therapy over postoperative therapy for resected or localized pancreas cancer include early treatment of micrometastatic disease. We know this is a disease that tends to spread very early in the course of disease. And so the earlier you give systemic therapy, the earlier you can address that microscopic disease. Neoadjuvant therapy allows improved delivery of treatment. And in general, patients tolerate systemic therapy much better prior to having a major abdominal surgery. We also have pretty strong data to support, particularly in borderline resectable pancreas cancer, that neoadjuvant therapy with chemotherapy or chemoradiation can improve upon the historical R0 resection rate. And what we don't know, but that most of us suspect, is that neoadjuvant therapy can help to select patients with the highest chance of benefiting from resection, essentially allowing you to avoid doing a non-therapeutic surgery in patients with unfavorable biology. So kind of the converse argument to this is that for a patient with a resectable pancreas cancer, we know that 10 to 15% of patients' disease progresses despite chemotherapy. And it certainly begs the question, would those patients have been cured with surgery up front? So this is the schema from SWOG 1505. These results were presented at ASCO's virtual meeting earlier this summer. This was a phase 2 non-comparative study, which evaluated 2-year overall survival with 2 perioperative regimens in patients with resectable pancreas cancer. So eligible patients were randomized to receive either perioperative FOLFIRINOX or gemcitabine and nab-paclitaxel. It's important to recognize when you're looking at this data that this trial wasn't actually powered to directly compare these regimens to each other, but they essentially each they designed it so each arm would be compared to a historical control, and they used an overall survival of 40%. So you can essentially think of this as kind of 2 parallel single arm phase 2 studies that happen to have the exact same patient populations. So they essentially gave 12 weeks of chemotherapy up front, restaged patients, they underwent surgery, assuming that they still had resectable disease, and then the plan was for them to receive an additional 12 cycles of chemotherapy following surgery. Both arms of this study met their primary endpoint. So 2-year overall survival was 43% in the FOLFIRINOX arm and 46.9% in the gem nab-paclitaxel arm. They did set a target of 58%. So if either of the regimens exceeded that 2-year overall survival, they would directly compare to each other. Neither of them met that criteria. And then you can see R0 resection rate was high in both arms, 85%. Complete or major pathologic response was 25% and 42% in each arm. And otherwise, they were generally pretty balanced between the two. So what can we say from this data? That basically perioperative modified FOLFIRINOX and gemcitabine with nab-paclitaxel had pretty similar efficacy, acceptable toxicity, and resection rates. This trial has been discussed a lot. I don't know if anybody's on Twitter, but there's been a lot of discussion on Twitter about this, as well as at the ASCO meeting, they had a nice discussion about. But there's been a lot of discussion about the high pathologic response rate in the gemabraxane arm, because historically, at least objective response rates by imaging have been far better with FOLFIRINOX. And so that's kind of emerged as a standard approach to neoadjuvant therapy. But again, it's important to note that these trials were really not powered to compare to each other. So if you actually look at the response, the pathological response, it's actually a difference of 4 patients. And we're talking, a trial of 70 some patients. And so you really can't draw the conclusion that gemcitabine nab-paclitaxel would be better. The other thing that's always gets brought up is that these survival numbers, while they look great, they're nothing close to what we saw with adjuvant FOLFIRINOX. And kind of the issue with that kind of discussion is that if you look at adjuvant studies, they're always going to have better outcomes than perioperative studies, because you've already selected for patients who have resectable disease, they're able to undergo surgery, they're able to recover from surgery within some window, usually 12 weeks from surgery, where they're well enough to get chemotherapy. And then oftentimes they re-image those patients to confirm that they don't have radiographic metastatic disease. And many of them also have a CA19-9 threshold, so that patients with a CA19-9 above, say, 100 aren't eligible for the trial. So adjuvant studies in general are selecting the best of the best patients. So they're really selecting the cream of the crop. So it's, trying to make cross-trial comparisons in this setting is highly problematic. I'll talk a little bit about radiation, but again, I'll leave most of this to Chi. The primary goals are to sterilize vessel margins, increase the likelihood of R0 resection, which we know has been closely associated with overall survival in this disease, as well as to enhance local control and prevent local disease progression. So probably the randomized trial that kind of best supports the use of neoadjuvant radiation therapy was the PREOPANC trial. This was the Dutch randomized phase 3 trial that included both resectable and borderline resectable pancreas cancer. They compared upfront surgery and adjuvant chemotherapy with gemcitabine to preoperative gemcitabine, chemoradiation with gemcitabine, followed by surgery, then adjuvant gemcitabine. This trial did not meet its primary endpoint. Overall survival was 16 months versus 14.3 months, but was not statistically significant. However, if you look at R0 resection rates, the R0 resection rate was significantly higher in the neoadjuvant chemoradiation arm compared to the upfront surgery arm. And just to highlight, an R0 resection rate of 40% is incredibly low. That means 60% of your patients have positive margin. And if you think of virtually any other disease in medical oncology, this would be totally unacceptable. And then in a subgroup analysis, we saw that in borderline resectable pancreas cancer, there did appear to be an overall survival benefit. This didn't pan out when they did a more detailed, thorough statistical analysis, but certainly a signal that, that this population, patients with borderline resectable disease, probably have the highest potential to benefit from chemoradiation. So this trial, this Alliance 21501 trial, this is a phase 2 trial of preoperative chemotherapy with FOLFIRINOX versus chemotherapy followed by chemo-RT, then surgery, followed by adjuvant chemotherapy. I believe it's close to accrual, but it hasn't reported out yet. This will probably give us a little bit more data about the benefit of upfront or neoadjuvant chemoradiation in patients with borderline resectable disease. So I wanted to go back and talk a little bit. We have a lot of kind of rational reasons that we like to think about giving neoadjuvant therapy, but many of these are supported by the data that we have. So this adjuvant FOLFIRINOX column is the Protease trial that I alluded to on my first slide. And this neoadjuvant modified FOLFIRINOX trial was a trial in borderline resectable pancreas cancer where they gave 8 cycles of neoadjuvant FOLFIRINOX and then selective chemoradiation. So they offered radiation to patients who still had borderline resectable disease or arterial involvement. And just looking at the kind of degree of chemotherapy delivery in each of these studies, you can see in the adjuvant FOLFIRINOX trial, only 66% of patients were able to receive all planned cycles of chemotherapy, with the grade 3 adverse events rate being almost 80%. As opposed to in the neoadjuvant setting, 81% of patients were able to receive all planned cycles of chemotherapy, but notably their adverse event rates was substantially lower. I will mention that in this trial, there was a proportion of patients who didn't receive modified FOLFIRINOX, and modified FOLFIRINOX essentially substantially reduces the incidence of diarrhea and neutropenia, and so that played into some of this, but it was a minority of patients who received the non-modified FOLFIRINOX. Kind of the feasibility of neoadjuvant versus adjuvant chemotherapy is also highlighted here in this figure from the SWOG 1505 trial. 85% of patients in each arm were able to complete preoperative chemotherapy. After surgery, about 55% were able to start postoperative therapy, and less than half completed all cycles of chemotherapy. Just further highlighting that trying to give chemotherapy after surgery for these patients is problematic. The other rationale for giving neoadjuvant therapy for this disease is to increase R0 resection rate. As I highlighted earlier, particularly in patients with borderline resectable disease, there seemed to be a substantial improvement of R0 resection, 79% versus 13% in patients with upfront surgery. And in the SWOG study, this is resectable disease, but after chemotherapy, the R0 resection rate was 85%. So we don't have great data regarding whether or not upfront chemotherapy can help select patients who are most likely to benefit from surgery. We assume that patients who develop disease progression on neoadjuvant therapy would have likely developed metastatic disease following upfront resection, but this remains unproven as perhaps one of the most important questions, particularly in resectable pancreas cancer, that's being addressed by ongoing randomized trials. And I alluded to this a bit earlier, this just highlights trying to compare survival outcomes from neoadjuvant therapy trials to adjuvant trials, and that in general, we expect that perioperative trials would have much worse outcomes than adjuvant trials, again, because you don't get to cherry pick your patients. You're selecting patients who may develop disease progression on neoadjuvant therapy, who may not be eligible for surgery, that sort of thing. I wanted to highlight this data because this is probably our most reliable way to measure response to neoadjuvant therapy is actually by using CA19-9 response in those patients who make CA19-9. So we know CA19-9 is prognostic for patients with pancreas cancer. And this study comes out of Medical College of Wisconsin from Doug Evans' group. They looked at patients who underwent resection for pancreas cancer who received neoadjuvant therapy and essentially asked, what's the best way to predict outcome using CA19-9? And what they were able to show is that actually normalization of CA19-9 following neoadjuvant therapy is most associated with overall survival. So it's not necessarily the magnitude of reduction of CA19-9, but the CA19-9 dropping to a level that's within the normal range, so below 35. And so there's ongoing studies trying to evaluate, well, is this an actionable thing, or is it simply a prognostic factor that patients whose CA19-9 drops with chemotherapy tend to do well, or does treating to normalization of CA19-9 improve outcomes for patients who then undergo resection? This is an ongoing trial, just opened. Alliance 21806 is a phase 3 trial that's randomizing patients with resectable pancreas cancer to either neoadjuvant chemo, 8 cycles of modified FOLFIRINOX, or upfront surgery, followed by adjuvant therapy. And so this should hopefully answer the question of, what is the benefit of giving neoadjuvant therapy to patients with resectable pancreas cancer? Quan went over this a little bit, but in general, I just wanted to highlight what the guidelines say. For resectable pancreas cancer, the NCCN guidelines recommend considering neoadjuvant therapy, particularly in high-risk patients, which they define as very high CA19-9, large primary tumors, large regional nodes, excessive weight loss, or extreme pain. And so typically we offer neoadjuvant therapy to most patients with resectable pancreas cancer, but it is by no means the standard of care. In borderline resectable pancreas cancer, I would say that neoadjuvant therapy is becoming a standard and it's recommended in the guidelines. But there's very little evidence to recommend a specific regimen, and the role of chemoradiation is not so well defined in the guidelines. And so to kind of summarize, neoadjuvant therapy we know is safe, it's more tolerable and more likely to be delivered than adjuvant therapy. But chemotherapy alone cures very few patients. So it requires careful delivery to make sure you're not destroying the patient with your chemotherapy so that they don't have a chance to have surgery. And this is particularly important if you're deciding to give neoadjuvant therapy for resectable disease. When we're deciding whether or not to give neoadjuvant therapy, we consider tumor-related factors, which I know Quan discussed some of, but also patient factors. So age, do they have known genetic alterations, which we know might make them more sensitive to platinum-based therapy? Look at their performance status, comorbidities, particularly patients with peripheral neuropathy. It can be challenging to deliver good doses of systemic therapy, and then monitor closely for chemotherapy tolerance. But probably most importantly, the tumor itself becomes unresectable if your patient's unfit for surgery. And so we're always very careful in giving neoadjuvant therapy, and that we're not beating the patient up too hard, ruining their chance to have the procedure, which is the only way that we know to cure their pancreas cancer. So I had a couple cases, which I don't have time for. That's all I've got. I'll quit.